Welcome to another episode from the Veterinary Medicine Digest. Today we are embarking on a deep and comprehensive journey into one of the most daunting clinical presentations in feline medicine, the cat that suddenly cannot walk. Specifically, we are looking at cats presenting with non-ambulatory tetraparesis or tetraplegia. For many veterinary practitioners, these cases trigger a sense of immediate concern, and sometimes even a touch of what researchers call neurophobia. This is a recognized phenomenon where clinicians feel a sense of paralysis when faced with the complexities of the nervous system, often due to the perceived difficulty of applying basic science to a live clinical case. But over the next hour, we are going to break down the latest research to show that with a logical approach, identifying the cause of a collapsed cat is not only possible but can lead to successful outcomes without always requiring invasive or prohibitively expensive interventions. To start our discussion, we must establish a common language for how we describe these patients. Negrin and colleagues provide a vital foundation for this in their work on the paralyzed cat. They define tetraparesis as a reduced ability to perform voluntary movements or support weight in all four limbs. If the patient has no voluntary movement at all in those limbs, we use the term tetraplegia. It is crucial to distinguish this from the quality of spinal reflexes. A cat can be completely paralyzed, meaning it has zero voluntary motor function, yet still have normal or even exaggerated spinal reflexes if the lesion is located in the upper motor neuron pathways. Conversely, if we see reduced muscle tone and absent reflexes, we are likely looking at a lower motor neuron problem, which points us toward the neuromuscular system or specific segments of the spinal cord. When a cat is presented in this non-ambulatory state, our first task is localization. Is the problem intracranial or extracranial? Negrin points out that if the mental status, cranial nerves, and menace response are all normal, the lesion is almost certainly extracranial, involving the spinal cord or the peripheral neuromuscular system. If we see an obtunded or stuporous mental state, or abnormalities in how the eyes move or how the face functions, we must look toward the brainstem or the forebrain. This initial division is the compass that guides every diagnostic step that follows. Once we have localized the problem, we need to organize our list of possibilities. A classic and highly effective way to do this is the vitamin D mnemonic, which stands for vascular, inflammatory or infectious, traumatic, anomalous, metabolic, idiopathic, neoplastic, nutritional, and degenerative. Mella and colleagues have shown that by systematically looking at discrete clinical variables like age, speed of onset, and whether the cat is in pain, we can statistically predict which of these vitamin D categories is most likely. For example, their research indicates that older cats are more likely to suffer from non-lymphoid neoplasia or ischemic myelopathy, while younger cats are more frequently seen for fractures, feline, infectious peritonitis, or traumatic spinal cord contusions. They found that spinal pain is a hallmark of conditions like intervertebral disc disease and fractures, whereas it is notably absent in cats with ischemic myelopathy. These easily identifiable clinical features are the keys to unlocking a diagnosis even before advanced imaging is performed. Let us dive into some of the specific conditions that can lead to a non-ambulatory state, beginning with trauma. One fascinating and relatively rare condition is traumatic atlantoaxial hyperflexion, sometimes called a Den's contusion. Llanos and his team at the Royal Veterinary College recently published a case series of 8 cats that were suspected of having this injury. Typically, these were young male domestic short-hair cats that had been involved in a road traffic accident or a fall. They would arrive at the hospital in a peracute state, meaning the signs hit them all at once, usually resulting in a non-painful, non-lateralizing myelopathy affecting the 1st through 5th cervical spinal cord segments. When these cats underwent magnetic resonance imaging, the researchers found a very specific signature, a solitary focal lesion located immediately dorsal to the dens of the axis bone. Interestingly, even though these cats often presented in a severe state, some completely tetraplegic, the prognosis for medical management was generally good. In their study, 75% of the cats showed improvement or complete recovery with medical treatment alone, which usually involves strict rest and supportive care. This highlights a recurring theme in our discussion today: severity of presentation does not always equal a poor prognosis. However, not all causes of feline paralysis have such a hopeful outlook. We must talk about feline infectious peritonitis, specifically the neurologic form. Crawford and colleagues conducted a multi-institutional study of 24 cats with histopathologically confirmed neurologic feline infectious peritonitis to better understand its clinical and imaging features. This condition primarily affects young cats, often less than 3 years of age, coming from multi-cat environments. The clinical presentation of neurologic feline infectious peritonitis can be variable, but Crawford identified 3 distinct syndromes: a myelopathy affecting the thoracic and lumbar segments, a central vestibular syndrome, and a multifocal central nervous system disease. On magnetic resonance imaging, these cats showed striking abnormalities, including inflammation of the meninges and the ependyma, which is the lining of the ventricular system in the brain. They also frequently displayed ventriculomegaly, which is an enlargement of the ventricles, often caused by the inflammatory debris obstructing the normal flow of cerebrospinal fluid. Sadly, unlike the traumatic cases we discussed, feline infectious peritonitis remains an invariably fatal disease of the central nervous system, and all cats in their study were eventually euthanized due to the severity of their signs. Moving from the central nervous system to the peripheral system, we encounter the complex world of feline polyneuropathies. These can be particularly challenging because they can mimic spinal cord disease. Bensfield and colleagues took a deep look at a specific cohort of 37 young Bengal cats that suffered from a chronic relapsing form of polyneuropathy. These cats usually showed up with weakness in all 4 limbs or just the back legs, often accompanied by a stiff gait or a plantigrade stance, where they walk low on their hocks. When the researchers looked at nerve biopsies under the microscope, they saw evidence of repeated cycles of demyelination and remyelination. Basically, the insulating sheath around the nerves was being stripped away and then trying to grow back. The good news for Bengal owners is that most of these cats eventually recovered, though some had relapses or residual weakness. Van Canegem and his team expanded on this by looking at 55 cats with suspected immune-mediated polyneuropathy across various breeds. They noted a strong similarity to acute motor axonal neuropathy, a variant of Guillain-Barré syndrome in humans. Most of these cats were young, with 91% being under 3 years of age. Much like the Bengal study, they found that the prognosis for recovery was excellent, with or without corticosteroid treatment, though about 28% of cats would have multiple episodes over their lifetime. Now that we have built this background, let us turn our attention to the main feature of today's episode, a landmark study by Guido Bertoldi and Stephen De Decker, published in 2026 in the Veterinary Record. This study is the first of its kind to evaluate which combination of clinical information is truly useful for a general practitioner when faced with a non-ambulatory tetraparetic or tetraplegic cat. They retrospectively analyzed 81 cats presented to the Royal Veterinary College over a 13-year period. Their findings were both surprising and incredibly practical. While they recorded 18 different possible diseases, more than 82% of all the cases were represented by just 6 conditions. These 6 are polyneuropathy, ischemic myelopathy, spinal cord neoplasia, feline infectious peritonitis, intracranial neoplasia, and spinal cord contusion. Even more striking is that polyneuropathy and ischemic myelopathy together accounted for half of all the cases. This is a powerful piece of information. It means that when you see a cat that cannot walk on all 4 legs, there is a 50% chance it has one of these 2 conditions. And why does that matter? Because both polyneuropathy and ischemic myelopathy can have very positive outcomes without the need for surgery or advanced, expensive treatments. Bertoldi and De Decker used multivariable analysis to see which clinical signs pointed most strongly to these 2 big players. For polyneuropathy, the most significant indicators were an age of less than 3 years, a progressive clinical course, normal mentation, reduced spinal cord, reflexes in the front legs, and normal blood tests. This makes sense when we think about the immune-mediated nature of the disease often seen in young cats. Interestingly, while reduced reflexes in the back legs were actually seen in 100% of the polyneuropathy cats, the statistical model chose the front leg reflexes as the better discriminator because they were more unique to that group compared to others. On the other hand, ischemic myelopathy presented a very different clinical picture. It was most strongly associated with older cats, specifically those between 6 and 9 years or over 9 years of age, and a peracute onset of signs. Ischemic myelopathy is essentially a stroke of the spinal cord, often occurring in the territory of the ventral spinal artery. Simpson and colleagues, in their study of older cats with this condition, noted that it frequently involves the 2nd or 3rd cervical vertebrae because the ventral spinal artery is at its narrowest there. One classic sign they noted was cervical ventriflexion, where the cat's head hangs low because the muscles in the neck have lost their nerve supply. These cats often have underlying medical conditions like hypertension, chronic kidney disease, or heart disease, so a full systemic workup is vital. The study also shed light on the less common, but still important, conditions. Cats with spinal cord neoplasia were typically older than 9 years and had a slow, chronic onset of signs that got progressively worse over time, often accompanied by spinal pain. Intracranial neoplasia or brain tumors were associated with an older age, usually between 3 and 9 years, and an obtunded mental status, meaning the cat was not as alert or responsive as it should be. They also frequently had an abnormal menace response. So how do we put all of this into practice? Bertoldi and de Decker argue that the single most important task for a clinician assessing a non-ambulatory cat is to differentiate between a neuromuscular disease like polyneuropathy and a disease of the cervical spinal cord like ischemic myelopathy or a tumor. This is done through a careful neurological examination. They recommend paying close attention to the cat's gait when supported, its muscle tone, and its spinal reflexes. If you see a cat with a short-strided gait that can still perform postural reactions when you support its weight, but it has generalized low muscle tone and an abnormal palpebral reflex, that is the blink reflex, you should be thinking about the neuromuscular system and polyneuropathy. If the cat has a long-strided, uncoordinated gait with absent postural reactions and perhaps a low head carriage, the problem is likely in the neck. The beauty of this research is that it helps practitioners prioritize their diagnostic plans. If the clinical picture strongly suggests polyneuropathy in a young cat, you might start with electrodiagnostics or nerve biopsies. If it looks like ischemic myelopathy in an older cat, you should be checking blood pressure and looking for underlying organ disease. While these reasoning tools cannot replace the need for definitive testing, they provide a roadmap through the fog of neurophobia. It is also important to remember that even when the clinical picture looks grave, many of these cats have a fighting chance. Ischemic myelopathy, for instance, has a high survival rate to discharge, with many cats regaining the ability to walk within a few days or weeks, even if they have some lingering deficits. Polyneuropathy also carries a favorable prognosis for recovery, even if relapses occur. This is a vital message to convey to owners who might be tempted to choose euthanasia out of a fear that their cat will never walk again. As we wrap up our discussion, let us reflect on the power of clinical reasoning. By combining the signalment, the history, and a focused neurological examination, we can break down a complex, overwhelming presentation into a manageable list of priorities. We have seen how specific research into densities contusions, Bengal polyneuropathies, and ventral spinal artery strokes all feed into this larger framework of understanding the non-ambulatory cat. In the case of traumatic DENS contusion, we know to look for that solitary magnetic resonance imaging lesion and to be optimistic about medical management. In cases of suspected feline infectious peritonitis, we look for the characteristic enhancement and ventriculomegaly while acknowledging the grave prognosis. In the older cat with a sudden neck hang, we investigate for hypertension and wait for the improvement that often follows a vascular event. And in the young Bengal or mixed breed with a progressive weakness, we look toward the nerves themselves, knowing that recovery is the most likely path. The work of Bertoldi, de Decker, and all the researchers we have discussed today serves a singular purpose to increase the confidence of the clinician and ensure the best possible care for our feline patients. They remind us that the nervous system, for all its complexity, follows rules that we can observe and interpret. When we approach a collapsed cat not with fear, but with a logical and systematic mindset, we honor the science and the bond we have with the animals in our care. Thank you for joining us on this deep dive into the neurology of the non-ambulatory cat. We hope this information helps you feel more prepared the next time a tetraparetic cat walks, or rather, is carried into your clinic. By focusing on the details that matter and applying the latest evidence, we can move past neurophobia and toward better clinical outcomes. Thank you for listening. The titles for the reference papers are in the video description. From VetMed Digest, where we keep minds inspired, hearts light, and tails wagging.